warm welcome everyone. Welcome to our channel medicaldafossa. Now let's continue on with the topic of breast carcinoma. Today we are going to discuss about the types of breast carcinoma. Now let's move on to the topic. All breast malignancies, they are adenocarcinomas. Now what are adenocarcinomas? Adenocarcinomas, they are nothing but they arise from the glandular tissue. In case of breast cancer, where they arise from? They arise from the milk secreting glands. All breast carcinoma arise from the cells in the terminal duct lobular unit. Now coming to the classification, they are classified into two types, the invasive and the in situ type. In case of invasive, it is further classified into special type and a non-special type. In situ type, it is classified into ductal and lobular carcinomas. Now let's discuss about the carcinoma in situ. Cancer cells in carcinoma in situ are confined within ducts and lobules by a basement membrane. In ductal carcinoma in situ, proliferation of cells are confined within the ducts and lobules by a basement membrane, and they can be detected by using mammographic screening. They are seen as calcifications associated with secretory materials or necrotic material in mammography. A palpable mass can be less commonly found in the ductal carcinoma in situ, and ductal carcinoma in situ rarely produces a nipple discharge also. Now coming to the morphology, ductal carcinoma in situ shows a mixture of growth pattern. The first comes the comedotype type. That shows nodularity in it and can be detected as areas of calcification. It can be defined as cells with pleomorphic and high-grade nuclei, and there will be areas of central necrosis. Here below a diagram showing comedodca's having central necrosis. This is the necrotic area and surrounded by neoplastic cells. The next comes the cribriform DCAS. It consists of rounded cookie cutter spaces filled with calcified secretory material. This is a diagram of cribriform DCAS having cookie cutter spaces having secretory material in this. And next comes the micropapillary DCAS having bullous protrusions without a fibrovascular core in it. And next comes the papillary DCAs having true papillae with fibrovascular core in them, and they lack a myoepithelial layer. This diagram shows the image of a papillary DCAs having finger-like. Papillary are nothing but finger-like projections. You can see finger-like projections in it. Now we are going to discuss about Paget's disease, which is a manifestation of breast, and there is also Paget's disease which belongs to bone. Now this is a manifestation of breast, and it's a rare presentation, and it presents as unilateral erythematous eruption. They present as scale crust, that is, you can see scale over the breast tissue, and it can be mistaken for eczema, and it could be pruritic also, that is, it would be itching. There can be presence of palpable mass also, and there will be predominance of HER2 overexpression. The malignant cells arise from the ductal system, so it is a manifestation of the DCIS. The malignant cells migrate via laciferous ducts to the nipple skin without crossing the basement membrane. Here it's an important point to note here that it does not crosses the or breaches the basement membrane, and the extracellular fluid oozes out of the nipple. This Paget's disease is detected by nipple biopsy. Now this diagram shows the migration of the invasive carcinoma cells in the Paget's disease. Now this is the basement membrane. Can you see any breach in the basement membrane? Yes, this is the speciality of Paget's disease, that it does not cause any breach in the basement membrane, and it helps in the local spread and the progression of the carcinoma. Now coming to the clinical features of DCAS, if a DCAS with low grade is left untreated, it can lead to development of invasive cancer in only minority of population, that is only 1% of people, while high grade DCAS can develop into invasive carcinoma at a faster rate. Now diagnosis. Diagnosis can be made through mammography screening. Mammography have created a revolution in the screening of breast carcinoma and reduced the overall death. The death after diagnosis occurs in only 1% to 3% of women. Now coming to the treatment, there are two surgical ways of treating the breast carcinoma. The first comes the mastectomy. In mastectomy, we will be removing the entire breast tissue itself, which causes reduced recurrence, and breast conservation. We will be conserving the breast and we will be excising only the carcinomatous part, which causes recurrence. There are certain risk factors which determines recurrence. The first comes the high nuclear grade and the necrosis. Next comes the extent, that is spread of disease up to which the disease have spreaded. Now the positive surgical margins, that is after surgery the excised mass is sent for pathological examination, where the margins are examined for the positive cancer cells in it. Now, the recurrence can be reduced by post-operative radiation therapy and tamoxifen. Giving tamoxifen, it's a drug. Now coming to the lobular carcinoma in situ, it's the most common type of breast cancer where the cell grows and proliferates in a discohesive fashion, which means here is a cell which divides. Normally it will adhere with each other, but in discohesive fashion it will be separated from each other. I'll tell you the reason why it's separated later. Now the diagnosis it's incidental, which means the patient will go to hospital for some other reason, but he will be diagnosed as breast carcinoma, that is lobular carcinoma in situ. Lobular carcinoma in situ is more bilateral, which means development of carcinoma in both the breast than that of DCS, which is usually unilateral. More risk of development of invasive carcinoma, which means metastasis is more riskier in LCIS than DCIS. So a surgical removal does not lower the risk in LCIS. Now this is the histological diagram of cells showing discohesiveness. If you closely watch, you can see separations in between the cells. You can see this cell, this is separated, it will not adhere to other cells. Likewise, every cell will be separated and it will not be adhered to the adjacent cells. This is known as discohesiveness. Now pathogenesis, as I said before, the cells will be in discohesive fashion. The reason for this discohesive fashion is dysfunction of E-cadherin. This is reason for the loss of cellular adhesion. The E-cadherin causes cohesion of normal epithelial cells in the breast and also it will cause tumor suppression. The mutation of E-cadherin gene, that is the CDH1, causes loss of tumor suppression and there will be neoplastic proliferation. Now the morphology, there will be mucin positive signet ring cells and due to lack of E-cadherin, which causes these cells to become a round shaped cells without attachment to adjacent cells. The presence of neoplastic cells between basement membrane, which is pathology spread, is also seen. Now this is the image of signet ring cell. Now how will you find a signet ring cell? It will consist of a large vacuole at the center and the nucleus will be pushed to one side and there will be rim of remaining cytoplasm and the cell will be circular in shape. Here if you focus deeply in this diagram you can find signet ring cells in it. Now as I said it before, you can see histological feature of pathology spread where there will be presence of cancerous cells in between the basement membrane. But you cannot see Paget's disease which mainly affect the skin of nipple and areola. There will be no necrosis, secretory activity and calcification seen. In treatment you can use bilateral mastectomy, but it is very doubtful that this surgery will reduce the risk, and you can also use drugs like the tamoxifen. Let us discuss about the invasive carcinomas. Invasive carcinomas are two types as I said before. These are the non-special type and a special type. Let us discuss about it detailedly. Now coming to the non-special type of invasive carcinoma, majority of them are ductal adenocarcinomas, which on cutting produces a characteristic grating sound. There will be presence of chalky white desmoplastic stoma, which is nothing but the fibrous tissues around the tumor. Desmoplastic stromal reaction is present, which is nothing but the activation of the supporting stromal cells around the tumor, which causes deposition of more collagen and extracellular substances. And the mass present will be at a size of 2 to 3 centimeter and it will be irregular. It is radiodense, which is captured in the radiological film. Least commonly, it is also well circumscribed. Now this is the mammographic image and this is the gross image. In mammography, you can see this is the tumor, which is well circumscribed and having regular margins. Now in gross image, this is the tumor, which is also well circumscribed and having regular margins surrounded by the desmoplastic stromal tissue. Now the cancer, it may causes invasion to pectoralis muscle and can be become fixed to the chest wall, or it may invade the dermis and causes retraction of skin, or it may invade the central portion of breast causing retraction of nipple. Now the cancer rarely, sometimes it will present itself as the metastasis to axillary lymph nodes or distant sites. In such cases, the primary carcinoma is small and there will be presence of dense fibrous tissue and it will fail to produce a desmoplastic response. The primary carcinoma can be detected by using the MRI scans. Now this is the image. The first image shows the skin retraction and the next image shows the nipple retraction. Now coming to the grades of cancer, the grading is known as the Nottingham grading and it is done based on three components. The first is the tubule formation and the next is the nuclear pleomorphism and the last one is the mitotic counts. The grade 1, it's a well differentiated form where the cells will be growing in tubular or cribriform pattern and the cells will have a low proliferation rate. And the grade 2, which is a moderately differentiated type of cancer, where the cell will be growing in clusters, and there will be greater nuclear pleomorphism, and there will be higher number of mitotic figures in it. The grade 3, which is a poorly differentiated one, where the cells will be having ragged nets or solid sheets of cells. Cells will be present as ragged nets or solid sheets, and there will be irregular nuclei in it, and there will be high proliferation rate of cells in it. Remember, grade 1 will have lower proliferation rate, and grade 3 will have a higher proliferation rate. Now the first picture depicts the carcinoma, which is a grade 1 carcinoma, which is a well differentiated carcinoma having tubules in it. These are the tubules. It's a cut section of tissue having tubules in it, and it's a grade 1 carcinoma. Now the grade 2 carcinoma is the second picture, which shows pleomorphic nuclei in it. Pleomorphic nuclei are nothing but nuclei which greatly varies in shape and size. And the third picture depicting the grade 3 carcinoma, which is a poorly differentiated carcinoma. Here also you can see pleomorphic nuclei, but the pleomorphic nuclei, these are enlarged type of pleomorphic nuclei in it. Now coming to the invasive carcinoma of special type. We have completed non-special variant. In special type, the first is the lobular carcinoma, where the gene defect would be biallelic loss of CDH1 gene, and there will be mutation of E cadherin, which is responsible for adhering the cell together and keeping them together. There will be single loosely connected cells, and which is hardly visible in the imaging or the physical examination techniques, and there will be no desmoplastic response in it. Metastatic spread, including the peritoneum, retroperitoneum, the leptomeninges, causing carcinomatous meningitis, that is, it can even spread to brain also. And GET, ovarian and the uterine spreads are also seen. In male and female breast carcinoma, it can even spread to stomach, causing signet ring carcinoma of the stomach. Now coming to the morphology, there will be minimal desmoplasia, which causes difficult to identify them using the imaging and the physical examination techniques. Now there will be discohesive infiltrating tumor cells. Now tell me the reason why it is discohesive. Yes, you are right. It is due to mutation of E cadherin gene. We can see signet ring cells with mucin droplets in them, and the tubules are absent in them. Now this picture shows the signet ring cells. I have told you the description of signet ring cells before itself. These are rounded cells with nuclei pushed to one end and having a central vacuole in them and having a rim of cytoplasm around them. Now coming to the carcinoma with medullary pattern, these are BRCA1 associated carcinomas. Not all of them, but only 67%. The underlying mechanism here is the hypermethylation of BRCA1 promoter, which causes downregulation of the BRCA1 expression. And the tumor will show a better prognosis than other poorly differentiated carcinomas. This is important to note here, that they have a high number of infiltrating T lymphocytes. This is related to host immune response to the tumor. Now the cells will be having a pleomorphic nuclei, and there will be a large mitotic figures showing rapid cell division, and there will be non-infiltrative borders which shows metastasis is infrequent in them. This is important to note here. This is very important. Now there will be minimal desmoplasia in them, and there will be well circumscribed mass. This is a type of, that is the medullary carcinoma. It's a type of triple negative breast cancer. Other carcinomas showing triple negative molecular type is the secretory carcinoma and the low grade adenosquamous carcinoma. This secretory carcinoma, actually this is a carcinoma that mimics the lactating breast. Now let's see about the morphology and molecular subtypes of some cancers. The cancers which are ER positive and the HER2 negative cancers. These are the lobular carcinoma, mucinous carcinoma, tubular carcinoma, and the papillary carcinoma. Lobular carcinoma we have already discussed itself. Now the mucinous carcinoma. The mucinous carcinoma will be soft rubbery, and the borders are pushing or circumscribed, and the cells will be arranged in clusters. There will be small islands of cells in the large lakes of mucin. Now the tubular carcinoma, which will be, as the name suggests, having well formed tubules in them, and it will be sometimes mistaken for benign sclerosing lesion. It may be sometimes mistaken for a benign condition, but which happens to be a carcinoma. And the cells will be having a cribriform pattern, and calcifications are present in them. Now the papillary carcinoma, which produces a true papillae as the name suggests in them, and there will be fibrovascular tissues lined by tumor cells in them. Now other molecular subtypes, These are the overexpression of HER2, which means HER2 positive. The cancers which fall under this category are the apocrine carcinoma and the micropapillary carcinoma. Apocrine carcinoma, these resembles the cells that lie in the sweat glands. So only the name is given like apocrine carcinomas, and it will be eosinophilic. The micropapillary carcinoma will mimic the appearance of a true papillae and triple negative breast cancer, as I said before, which will show a carcinoma with medullary pattern in them. Now at last, the inflammatory carcinoma. In gross appearance, they will be showing lymphovascular spaces in them, and they will be having distant metastasis. They will be showing distant metastasis, so the prognosis is poor in them. They present as a breast erythema, a swelling, and a skin thickening. The important point to note here is the edematous skin mimicking the surface of an orange peel. This is known as the pudy orange appearance. This is the image of a breast showing pudy orange appearance. The name is inflammatory carcinoma, but you can see no inflammation in them. They do not form a discrete palpable mass, so there will be delayed diagnosis. Only when a patient notes a palpable mass in them, they will be coming to the OPD for diagnosis. These are high-grade tumors, but they do not belong to any particular molecular subtypes, like the ER positive, HER2 positive. Up to this, we have covered 80% of the breast carcinoma topic. In the next video, we will be seeing about the prognostic factors of breast carcinoma. Thank you.